Welcome to Vein Week and to our presentation from the College of Phlebology in the UK regarding two important subjects to discuss regarding vein health and techniques. So this part of the Vein Week is aimed really at healthcare professionals, although it's of general interest to anyone with interest in the subjects that we're going to talk about, which is phlebitis and also venous leg ulcers. Of course, as you'll hear over the week and with all the different presentations that are going around as part of Vein Week, there's a huge amount of interest in many different areas to do with veins, particularly pelvic veins, varicose veins, all sorts of aesthetic veins, nowadays stenting. There's so many things to talk about with veins, but we've focused down on two because these two areas, venous leg ulcers and phlebitis, are really not very well treated currently and are often misdiagnosed. So we're going to go through these to discuss these in detail as our contribution to the educational part for healthcare professionals for Vein Week. So before we start with the educational part, I would like to give a big thank you to Sergio Gianzini and for all the members of VWin Foundation who have set up Vein Week, and all the panelists and all the people who are sitting on the different committees to make sure that this Vein Week is a big success. So the two important subjects we're going to discuss as part of Vein Week is phlebitis, or what we call phlebitis, and then we're going to talk about venous leg ulcers. Now these two areas are very, very common in the general population and unfortunately are very badly treated and quite often not recognized correctly. So we're going to go through these in order. So we're going to start off with the first of our two subjects, and that one is phlebitis. Now, phlebitis, the very word phlebitis means inflammation of a vein. Itis means inflammation, and phleb means vein. And unfortunately, many doctors, nurses, vascular technologists, and other healthcare professionals, including patients as well, think that itis or inflammation always means infection. And in fact, in a great many places, you get inflammation with no infection at all. For instance, if you fall over and bang your knee, you get inflammation. Your knee goes hot, it goes red, it's tender and it's swollen, and it looks for all the world inflamed. And it is inflamed because that's part of the healing process. The problem is that you know that you fell over, you know you knocked it, and you know that that's the reason it's inflamed, so you don't think it's infected. When the same thing happens, but you can't remember hitting it, then you assume it's an infection. Because of this, we often misdiagnose any inflammation down the leg as phlebitis and give the most ridiculous treatments such as antibiotics for phlebitis. So we're going to go through this in order. We're going to explain why phlebitis is frequently misdiagnosed, why it's frequently mistreated, and we're also going to point out that one of the things that's not commonly known is in some cases missing phlebitis or mistreating it is a cause of preventable pulmonary embolism in some patients. Pulmonary embolism being a clot to the lungs. So this isn't just a minor point. It's not just like, oh, I've missed a small diagnosis. If you miss phlebitis and it's a serious phlebitis, it could go on to cause a life-threatening condition, a clot to the lungs. So these two patients here, these two legs, are the sorts of things that are often misdiagnosed as phlebitis. This one here over on the left-hand side, this inflamed red area around the ankle, many people when they see this say, oh, that's phlebitis, and it's not. That is lipodermatosclerosis. It's a general inflammation. This is almost always caused by hidden varicose veins. That's varicose veins you don't see on the surface. It's often treated by nurses and GPs with either steroids or with compression stockings, when in fact the proper treatment is to send the patient in for a scan and have the underlying perforating veins or truncal varicose veins removed, even though they can't be seen on the surface, and this will heal. Over here we have venous eczema, this itchy red patch here. On this case you can actually see the varicose veins. So once again, it's obvious this patient needs to come in, have a scan, and have the veins treated. So both of these are caused by having varicose veins or hidden varicose veins. I think of venous reflux. Both can be fully treated, but neither of them are phlebitis, even though they are hot and red and tender. This is an example of a true phlebitis. So in this case, it's in the upper thigh. It's a fairly straight red line tracking up to where the vein is because it is an inflammation of the vein. It's these tender lumps. If it's near the surface, you can see redness on the skin. Sometimes it's deep enough that you can't feel it. Now you can see in this patient, more concerning, they've had an older phlebitis over here, and this is in a branch or a tributary, as it should be called, of the great saphenous vein. This one here is in the great saphenous vein itself. So as you can see, we've written over here, these are tender lobes, often red, and often in the line of a vein, or in the place where you know there's a vein been before. This is a true phlebitis. So we should not use the word phlebitis at all. What we should talk about is superficial venous thrombosis, because this is exactly what happens. When you have got a vein that gets a clot in it, you can see this little animation, a clot can start forming in any outpouching or any other area of the vein that's not normal. And once you get the blood clotting in an area, that's a thrombus, then you get a propagated thrombus that blocks off the vein and goes further along the vein itself. And that irritates the vein, causing the vein to become inflamed. So the inflammation is caused by the clot. So what causes the clot? Well, a clot is caused by any one of three things that were outlined by Virchow in a triad called Virchow's triad. So anything that changes the vein wall, anything that changes the blood flow, and anything that changes the blood constituents can cause a clot. So for instance, varicose veins are very likely to cause a true superficial venous thrombosis or phlebitis, a clot, because you've got both changes in the vein wall and also changes in the blood flow. So you've got 2 out of 3. And remember, you only need 1 out of 3 to actually get a clot forming and a superficial venous thrombosis. You'll see this third one, the changes in the blood constituents, that happens if you smoke, if you're on the oral contraceptive pill, if you get dehydrated, and unfortunately in some patients if they have cancers. So in people who have any of those conditions or get into any of those drugs, that actually will enhance the fact that if you've got varicose veins as well, you're more likely to get a superficial venous thrombosis and therefore get the clinical signs of phlebitis. So to understand this further, let's look at the layers of veins in the legs. Now, unfortunately, many doctors think that there's only 2 sorts of veins in the legs, there's deep and superficial, and that is incorrect. There are 3 areas of veins. There's actually a bit more when we look in more detail, but to understand this sort of area, like superficial venous thrombosis or phlebitis, we must understand the 3 main layers of veins in the legs. The first layer is the deep veins, and the deep veins lie inside the muscle, deep inside the legs. Outside of the muscle is a thing called fascia. Now, fascia is like a stocking that covers the muscle. And on the outside of that deep fascia are the truncal veins. That's your great saphenous vein and your small saphenous vein. Also, there are some other minor truncal veins, such as the anterior accessory saphenous vein and posterior accessory saphenous vein, and some other smaller veins as well that sometimes are there or sometimes not having names. But all the ones that we need to concentrate on are these truncal veins called the saphenous veins. Now, the saphenous veins have their own little fascia around them called the saphenous fascia. And outside of that, in the fat of the leg or just under the skin, we have the superficial veins, which are the ones that dilate in varicose veins to cause the lumps, which are varicosities. And you can see this here. And these are the lumpy ones we see on the surface if they dilate. And if they're a bit deeper, sometimes are not too dilated, sometimes you can miss them. So the most minor sort of superficial venous thrombosis is when just this outermost layer, the third layer, the most superficial one, gets a thrombus or a clot in it just underneath the skin. And that's a very simple superficial venous thrombosis. However, that superficial venous thrombosis might actually extend into the saphenous vein, and it might go quite high up the leg and also further down the leg. But on the surface, again, you might only know the same area. So without being able to look inside the leg, you won't know the difference between the first of these over here, where you've just got a clot locally, or you've got this clot that's shown locally, but also extends right up the saphenous vein. Unfortunately, this is what the latest research has shown, and we'll come on to this in a bit. If that clot extends all the way up and into a deep vein, that's when you can get what's like a deep vein thrombosis. That thrombosis goes into the deep vein, and that's when it can break off and travel to the lungs. So therefore, it's silly to call all of these just phlebitis when one is a little local inflammation. and the other one is potentially lethal, throwing clots up to the lungs. And so this is why it's really important we drop the name phlebitis and we call this superficial venous thrombosis, so we can start to understand the severity of this condition in some patients. So, is there any evidence for what I'm saying, or is this just me beating my chest about something I believe strongly about? And of course, I wouldn't do that if I couldn't prove it or didn't have very good evidence. And back in 2012, there were guidelines both from the US and also from the UK, and here's the references over here. And both of these said that if you have a superficial venous thrombosis and it gets close to the junction with the deep vein, and they say between about 5 and 7 centimeters, you must have anticoagulation. That's proper anticoagulation. Not just aspirin, but you must anticoagulate with warfarin or with one of the new anticoagulants, the direct acting anticoagulants, which you can take orally to stop this clot from extending and therefore reducing the risk of a pulmonary embolism. So in summary of what was said so far, we know that we really shouldn't use this word phlebitis at all. And what we should do is we should call this superficial venous thrombosis. Because once we hear that word thrombosis, we'll start to understand this is a serious condition or potentially serious. It's absolutely essential that every healthcare professional and also every patient knows that this inflammation that is due to the superficial venous thrombosis is due to thrombosis, in other words, clotted blood, and it is not an infection. That's really key. So when you see phlebitis or superficial venous thrombosis and you see that red mark going up the leg, it is not an infection if it is due to clot in the vein. The treatment of the superficial venous thrombosis depends on that clot position. Is it or is it not deep, close enough to the deep vein that it could go on to cause a pulmonary embolism? And of course, this is the key point. All patients who have been diagnosed with, so say, phlebitis or superficial venous thrombosis must be referred for a duplex ultrasound scan. Without a duplex ultrasound scan, firstly, you can't tell, is this actually a superficial venous thrombosis? Is it due to a clot, or is it a tracking cellulitis or a lymphangitis? Is it something else that might cause some redness up the leg? So you might be very clinically convinced that this is a phlebitis or a superficial venous thrombosis. You might have a lumpy hot red vein, but you need to have a duplex scan firstly to confirm the diagnosis, but secondly, you absolutely have to know how far up those truncal veins does this clot go and how close to the deep veins is it. And without a duplex scan, you're just guessing. And this is the reason. No patient should ever be given antibiotics for this unless they have a superadded infection, which is highly unlikely. This hot red area that's lumpy and looks infected because it's so inflamed is actually an inflammation. Now, if the duplex shows that the clot is away from the deep veins, it's quite normal to give anti-inflammatories such as aspirin or indomethacin, Nurofen, something along those lines, provided the patient is able to take them, not allergic or not have asthma, and also support stockings. However, if that clot is getting near the deep veins, in other words, 5 to 7 centimeters away or closer, then that patient should have anticoagulation by the guidelines. So it's absolutely essential that patients who have this diagnosis are sent for an urgent duplex ultrasound scan, and the treatment should either be anti-inflammatories if able to be taken and support stockings if it's a safe one that's a long way away from the deep veins, or if it's near the deep veins, anticoagulation to stop the clot from progressing into the deep veins and becoming pulmonary embolism. Absolutely no one needs antibiotics if it is a true superficial venous thrombosis. So we're now going to look at the second of our conditions that's badly treated internationally as well as nationally. Because the College of Phlebology, although we are an international college, we are based in the UK, so the figures from the UK are going to be presented here. So we know that there's approximately 500,000 people in the UK with what's called a recurring venous leg ulcer. In other words, at any one time, about 125,000 have an open venous leg ulcer and the others are in compression, trying to make sure they don't come back again. And that's because the standard treatment is compression, which is not a cure. It's merely holding something compressed, hoping it doesn't come back again without fixing the underlying problem. Now, depending which research you read, it costs the NHS in the UK something along the lines of £1 to £3 billion per year. It might even be more than that if you add all the nurses' salaries and all. This is really some more the equipment costs. But the lowest estimate I've seen is 940 or 980 million, and some people right up to £3 billion per year. Without doubt, though, it is an awful lot of money that every year increases with an older population, with more people getting venous leg ulcers. But as most of these patients are curable, and the cost of the cure is the same as only 1 year of dressing, it seems ridiculous that we're allowing these ulcers to continue to be dressed and compressed when we could cure most of them. So we have to know what the underlying causes of the venous leg ulcer are if we're going to cure it. And there's venous reflux, venous obstruction, and venous stasis. So firstly, we're going to look at the traditional teaching. So this is pre-1980s, although unfortunately it seems to be what most doctors in the UK and most nurses, especially those treating venous leg ulcers at the moment, seem to still rely on. So before the 1980s, it was thought that if you had what's called superficial vein reflux, so that's reflux where the valves are given way in that truncal vein called the great saphenous vein or the small saphenous vein, and then it comes out into the surface varicose veins, or in some patients you don't see this, you have hidden varicose veins. But if it's in the superficial veins here, it used to be thought that this causes varicose veins only, this is cosmetic, and it can be left alone without any problems. We now know that is incorrect, but it's amazing the number of people that still think varicose veins are only cosmetic and don't cause venous leg ulcers or any other problems. Before the 1980s, it was also thought that if you had deep venous reflux, in other words, it was going down those veins we saw in the layer that's inside the muscle, we thought that was deep vein reflux, and we thought the only thing that would cause was venous leg ulcers, swollen legs, the champagne bottle legs, brown stains around the legs that broke open into these open sores. And we thought that was a completely different condition. And in those days, we didn't think that these two systems of the legs were linked. So what this meant was that before the 1980s, we used to treat patients according to which one of these two conditions we thought they had. So if patients had just what's called superficial venous reflux or varicose veins, we would do a stripping in those days, remove the veins, and we thought we'd cured the patient. But the reality is it didn't really matter if we cured them or not, because in those days it was thought to be cosmetic only. Similarly, patients who were the other way around and had the deep vein reflux, well, there's no surgery that could be done to do that. We can't make new valves and we don't know what to do with this, or in those days they didn't. So what ended up happening was these legs were bound with compression bandaging or stockings to force this blood to slow down, not reflux so hard, and to cause less of an inflammatory process as it falls back down the leg. And there was thought to be no other condition. So once again, it was thought that if you have superficial vein reflux, varicose veins, it's easy. You can just treat it superficially if you want to, but it's only cosmetic. Whereas deep vein reflux caused leg ulcers, and if you had a leg ulcer, the only thing you could do was dressings and compression. But that was before the 1980s, and really this should be now ancient history, and it's such a shame that people still teach this and still believe it and still treat patients this way. So what's changed our thinking about venous leg ulcers? Well, unfortunately, for many people, it hasn't changed, as we've said before. But for those of us that keep up with the research and those of us who are pushing forward, we can track some of the papers that have really made a massive difference. So firstly, in 1984, this paper from Bournemouth showed that when you look at people with venous leg ulcers, they were quite surprised to find that they had assumed when they were doing the study that they were going to find just deep veins causing these leg ulcers. But when they had patients with leg ulcers and started using what was then a new test called duplex ultrasound, they found that a lot of them actually had normal deep veins, and some of them just had what used to be called long saphenous vein incompetence, but is now called great saphenous vein incompetence alone, or perforated incompetence alone. In other words, the deep veins were normal. And this is absolutely essential, because if the deep veins are normal, this shows that everything that I've just shown you on the previous slides is open to question, because we can treat these superficial veins and perforators. So all of a sudden, this was the first time that we thought that perhaps we could cure venous leg ulcers by varicose vein surgery. And some of those of us at this sort of stage were already starting to think along these lines. So almost 30 years ago, another paper came out showing that over half the patients with venous leg ulcers, when they were examined, had only what had previously been thought of were varicose veins. In other words, their deep veins were completely normal, but their venous leg ulcers were due to superficial vein reflux only. Now, as superficial vein reflux can be treated, this suddenly meant that, without doubt, we could treat many patients with venous leg ulcers and potentially cure them. But also, in addition, it meant that we shouldn't be thinking that people who've got varicose veins are only cosmetic, because some of these patients would have just been varicose vein patients who either hadn't bothered or hadn't been referred, but for one reason or another had never had treatment. And lo and behold, they ended up with venous leg ulcers. By 2007, this landmark randomized study was performed called the Eschar Trial, which didn't look at the new ways of treating veins. It did look at all ways of treating veins, so mainly stripping, but it showed that if you compare patients having just compression with those who have got venous surgery for their venous leg ulcers, and you follow them after treatment, those patients who had the surgery have fewer recurrent ulcers in the future. Those with compression alone have more recurrence, which is really quite an obvious thing that you would expect. After all, if you're doing surgery, you're making a permanent change. And therefore, if you're doing the right surgery, you should see a very low recurrence rate in ulcers. And that comes down to what sort of surgery and how do you do it. If you're using compression, you're only treating the ulcers on the day you have compression. So what you're doing is you're improving the local circulation when the compression's on. But as soon as you take it off, well, you haven't changed anything. So it's not really surprising that the veins that the ulcers start to come back again because you didn't treat the veins. So although this is a landmark trial, this is one of those things that really is so predictable. Somebody had to do the trial to prove it, but really it should have been one of those things that instead of everyone going, isn't this amazing? People should turn around and say, well, thank goodness somebody's shown what is obvious. In 2013, my own unit published 12-year results looking at the patients we had treated with venous leg ulcers over the previous 12 years. And in those group of patients who had come to us knowing their legs were venous, because we're a venous clinic, we had actually cured 85% of those patients coming in with venous leg ulcers. And of those, 53% had never used any more compression ever again. So that's a complete cure in 53% and 85% having a cure, and only 15% finding that they couldn't be cured with superficial venous surgery. And all of those were shown to have less pain, and so had had some improvement, even if not cured. So already by 2013, we were showing good cure rates for superficial venous surgery for people presenting with venous leg ulcers. In 2018, a second landmark randomized controlled trial came out, which really was an amazing piece of work that showed that if you used a new endovenous surgery, now unfortunately they didn't treat perforators and all the complex stuff, but even using the most basic endovenous surgery, you can cure venous leg ulcers faster than just using compression. So this trial showed that if you have a patient in front of you and you either say you are going to have endovenous surgery or you are going to have compression, you'll get a faster healing rate if you use the endovenous surgery. And what we know from the previous trials, from the Eschar study, we also know that if you choose the endovenous surgery, they've also got less chance in the future of getting their venous leg ulcers back. So these two randomized trials mean that really there should be no doubt at all now. If you have a venous leg ulcer, you should be assessed and, if suitable, should have endovenous surgery. So let's try and understand this in a bit more detail. So in a book I wrote in 2011 about venous reflux, one of the things I showed is that if you keep on hearing people talk about high pressure at the ankles or venous hypertension, in reality, it doesn't really exist at all. If you look at a patient who has normal veins, a patient who has varicose veins with great venous vein incompetence, and a person with a venous leg ulcer, provided they're all the same height, then all of them have the same pressure at the ankle. And that pressure is their height times rho, which is the density of blood, and if they're human, that's going to be the same, and g, which is gravity, which means that if they're on Earth, they will have the same as well. So the only variable is height. So provided all these patients are the same height, regardless of their veins, they all have the same pressure. So just saying varicose veins are due to pressure is clearly irrelevant and nonsensical, and thinking therefore that leg ulcers is due to pressure is also nonsensical. However, the only way you can think of venous hypertension, which does make sense, is if you think about it as dynamically. Now, this graph is trying to show this by saying if you're lying down at the beginning here and then you stand up, when you're lying down, the pressure at your ankle in the veins is about 15 millimeters of mercury. And when you stand up, it's going to go to, as we saw on the last slide, HROG. So however tall you are, that's going to be the pressure at your ankle. The difference is, how do you get there? If you have normal veins, then you follow this low line here, the very slow filling line, which is usually 20 to 40 seconds, something along that time. And that's because to fill up your leg, blood has to go through the arteries and fill the legs through the capillaries, which is a nice slow way. It can't fall down the leg because you have valves in the veins. If, however, you have lost the valves and you have venous reflux, when you stand up, blood falls straight out of the right heart, inferior vena cava, straight down, hits the ankle very, very hard. And this rate of change, you don't get any venous hypertension. There's no change of pressure at the top, but the rate of change is huge. This is, I always liken this to being punched. If you put your fist against a chin and push slowly over 20 to 40 seconds, it causes a bit of red mark, but nothing more. That's normal. If, on the other hand, you put the same total power, but in half a second, you'll probably knock the person out. If you want to think about spreading ribs during cardiac surgery, or a woman giving birth and thinking the difference between a slow labor and a fast labor, and whether you break the ribs in the cardiac surgery, whether you get tears during the pregnancy, whenever you're talking about moving or stretching tissue, any doctor or nurse or anybody, any scientist will know that this is correct, and will know that tissue, as long as you're slow and make slow changes, will stretch and not cause too much inflammation, but sudden changes cause damage and inflammation. So the whole damage that causes venous leg ulcers from varicose veins is because of the loss of valves, and because of that we get this sudden increase of pressure, not any extra pressure, but the sudden rate of change of pressure due to gravity. Now, hopefully you've understood that. So now we can go on to the next bit. So that's called passive reflux. So in other words, when you stand up, blood is falling passively down by gravity and getting this inflammation at the ankle. Now, I call it in my books passive. Some people call it gravitational. Many workers in this field or hemodynamic doctors call this diastolic, and I don't particularly like that because diastolic to me really refers to the heart. So if you ever see diastolic written, that's what it means. But so this passive reflux due to gravity is something that's only found in the veins that are open to the deep veins without any valves in the way. However, there is another sort of reflux in the legs, which is very common, and it happens in most patients in combination with that passive reflux, especially in people with leg ulcers. And unfortunately, this is really misunderstood even by surgeons who treat veins all the time. And you can see very, very clearly if a doctor knows what they're doing or not by just asking them if they treat incompetent perforators. The thing with this, and to try and help us understand it, is that whereas passive reflux is quite obviously only due to gravity, active reflux is in those veins down at the bottom of the leg, so the small saphenous here, or perforators, where there are competent valves above the point, and so therefore you can't have the reflux falling down the leg. So it can't be the same mechanism at all. And what happens in these cases is when you contract the calf so that you constrict the veins because of the outside action of the calf muscle or thigh muscle, blood not only squirts up the normal way, but because the valves have failed either in the small saphenous vein or the perforators, blood squirts out at a high pressure. And that same impact, the same rush of blood going out and hitting the skin causes inflammation, and they can end up causing the venous leg ulcers. This is looking at just one test called photoplethysmography, and looking at where doctors and also scientists in the area often go wrong. But this same principle is often used in Doppler or duplex examination. And that is that when you do any test, you tend to squeeze the muscle. With photoplethysmography, you actually get the patient to move their ankle 10 times. And you see the line going up here during the active phase here of the muscle contracting. And this line going up actually represents a decrease in pressure. It's sort of inverted from where you'd think it is. So this means you're pushing blood out of the leg, so the pressure is dropping. And then as soon as you stop moving and keep very, very still, the pressure starts increasing again. It comes back down to normal, nice and slowly over 60 seconds. And there is no reflux in here. So we know that this patient has got no reflux in their great saphenous vein. And this is what we're used to looking at. So we tend to ignore this side because we just say, well, that's when the patient's moving. But on this side, we're always looking for reflux. And that means that as doctors, we're trained to only look for this passive reflux. So if you showed a vascular surgeon who's not used to doing veins all the time they would instantly tell you that, well, this is when the patient was moving here, but look at this, on this side here, as soon as they stop moving, you get this gross reflux really, really quickly. That's that sudden return back to normal, and so that is where you have got passive reflux. So everybody agree that this person has passive reflux. This is a clear and obvious positive test for passive reflux. However, if you're looking for active reflux, you have to look at this side of the line. And look at this. What's very interesting is you started getting some reduction of pressure, but it's swinging quite a lot. And that's because as you're pumping each foot pump out, the blood is going up but falling straight back again. So you get these big swings of pressure. Plus, it's only after about 3 or 4 times you've moved, you've reached the maximum outflow you can get. That's the minimum pressure. And the rest of them really is just holding stable. So as you're pumping blood out, it's falling back. This is where we're seeing the effect of the active reflux. This is where the perforated or small saphenous vein are obviously causing a problem. So this patient, to the sharp eye, has got both active reflux and passive reflux. But because doctors are only trained really to look for passive reflux, or when they're using Doppler, they squeeze and then look. They don't look as they squeeze. This is the area most doctors look at. So to understand passive and active reflux, we have to really get our heads around this idea that reflux doesn't only happen after the muscle squeeze, but also during it. So why is this important? It's important because of the underlying causes of the venous leg ulcers. To understand those and then to treat them is going to give you the very good results in curing the venous leg ulcers. It is not sufficient just to treat the great saphenous vein passive reflux. You also have to treat the small saphenous vein active reflux. Most doctors treat that without understanding why. But also you have to treat the perforators. If you're treating the small saphenous vein, then you really should be understanding that you have to treat the perforators as well. I can never understand those doctors who treat the small saphenous vein but don't learn the Trlop technique to close the perforators. So here we have the range of the most common causes of a venous leg ulcer. On the left here, we see there's reflux going down just the great saphenous vein. So this is pure great saphenous vein reflux in the simplest possible way to draw it. And this is a gravitational or passive reflux. Next to it is a pure perforated vein reflux. The valves are working in the great saphenous vein and the deep veins, and it's only the incompetent perforator that is causing the venous reflux in this case. Those doctors who only scan the top of the legs will think this patient doesn't exist. The third group here are patients who have got passive reflux down here, the great saphenous vein and the incompetent veins. This is the commonest pattern we see with people with venous leg ulcers, that they've got truncal reflux and incompetent perforators as well. The fourth group are those more complex again because they've got deep vein reflux and superficial vein reflux and perforators. So they've got reflux in all of the different veins low down in the leg, but most importantly the deep veins as well. And the fifth group is that group that isn't that common, but people think all patients are this. This is before 1980, everyone thought all leg ulcers were like this, where it's just the deep vein reflux that is causing a problem. So those are the different sorts of patterns. What we're going to look at now is how can we address those patterns. So now we can see how we can approach all of these different patterns. The first patient who's just got the simple reflux in the great saphenous vein, I mean anybody who does veins should be able to treat that simple case We'll talk about the endovenous techniques and the new HIFU, high intensity focused ultrasound techniques that can cure these now. But really, that's the sort of bread and butter, the easiest way. And every surgeon who treats veins, or any doctor who treats veins at all, should be able to treat that. This is much more complex. Those patients who have got just perforated vein disease, and we see an awful lot of them, causing leg ulcers. There might be 4, 5, 6, 7, 8. This week I operated on someone with 6 perforating veins alone causing a venous leg ulcer. If you can do the Trlop technique or the HIFU technique to close these perforators, you should be able to cure these patients as well. Combination of both the great saphenous vein reflux and also perforated vein reflux, and of course small saphenous vein reflux mixed in there as well, that should all be treatable by a combination of those two techniques. And if you can do those, then 50 to 80% of all patients who can walk and have got good mobility in their ankles should be curable by these techniques if they have a venous leg ulcer and are mobile. Now, patients who have got deep vein incompetence, what's been shown is if you have deep vein incompetence and great saphenous vein incompetence, or small saphenous vein incompetence and perforated vein incompetence, or any combination of those, if you treat the superficial vein reflux, you will improve the patient, although not cure them, because you can't cure this deep vein incompetence simply, although you may be able to improve it even more with a stent, but we'll come to that later. If you only have deep vein reflux, then that's the one that we have got no treatment using a reflux type basis, although again, as 90% of these have shown to be due to obstruction, we can stent those as well. So we'll come to this later. The take-home message from this set of slides, though, is something like 50 to 80% of venous leg ulcers are curable, or certainly should be curable, if you can treat the great saphenous vein, small saphenous vein, and incompetent perforators. We haven't gone on to some of the complex things such as pelvic veins, but that's a bit more nuanced than this talk will allow. So up until this point, we've had a very nice story that if you find the reflux in one of the long veins, such as the great saphenous vein or the small saphenous vein, or both of them, and you can find the perforators and heal them as well, then you should be able to cure the venous leg ulcer. But we're missing out a little section here, and that is between the refluxing vein and the skin that breaks down to cause the ulcer. There's a network of veins that get dilated. So what happens is when you have that reflux, it goes into a network of veins that get more and more dilated, and this becomes like a Medusa's head. It's full of little snakes that you can see all under the skin on a duplex ultrasound scan. And these are full of blood that doesn't move very much, which is venous stasis. And what I've written in my book on leg ulcers is if this blood just sits there, moving just enough not to clot, but not getting flushed out, that blood becomes very, very acidic. It gets full of carbon dioxide. It also gets all the other products of metabolism in there, which are not healthy to have around. The cells are still respiring, and that causes the venous damage. And what Ronald Bush has shown is if you can actually close those veins with foam sclerotherapy directly, you can actually heal the ulcer just by treating those veins alone. And this is a fantastic technique which we use a lot in my own practice called the TIRS, where in fact we use it in combination with getting rid of the venous reflux, because if you just do this and don't take away the underlying reflux, of course, this could reopen again. So although this is a great technique and shows us how important the subalcer plexus is and venous stasis is, it's also very important to remember that you have to do it in conjunction with what caused it, and again the underlying cause, which is the reflux. So if you're just treating the venous reflux and not the subalcer plexus, you're doing half a job. If you're treating just the subalcer plexus, not the reflux, again you're doing just half a job. So if you do both together, usually with a few weeks in between them, that's when you get the long-term good results from venous surgery. So now we have the principles of how we should treat patients who have got superficial venous reflux. We have to talk about what techniques we can use. So the good old open surgery or stripping really should not have been done since about 1999, when we introduced the new endovenous surgery. Now, unfortunately, although I started doing endovenous surgery in 1999, that was very early, and most people didn't start using it until probably the early to mid 2000s in the early cases. And by the end of the 2010s, then people really should have all moved over to endovenous surgery, although you still do hear that some people are still stripping, which really should never happen. And this is these slides here show an ultrasound showing regrowing of the great venous vein here, 4 different veins regrowing where there was one before after stripping. This is where the vein is growing back along. This is where it's reconnected in the groin called neovascular tissue. So this area is strip tract revascularization, where the veins grow back along the strip tract, and when they regrow, they never ever have valves in them. This here is the reflux that you see. This had been tied once, but once the tie breaks down, it all just grows back and you get the same reflux back again. And we've proven this histologically as well. This was published in the Advances in Phlebology and Venous Surgery book over here. And you can actually see the different lumens of the veins on this slide. So when we started bringing endovenous surgery into the UK in 1999, I performed the first procedure in March 1999, but it didn't really start taking off until about the mid 2005s, 2006s. Some of the early people started doing it along with us in about 2001, 2002, but it wasn't until about 2010 onwards that it really started gaining traction. By 2013, the NICE guidelines in the UK actually published their CG 168, which said it is actually the way that should be preferred to treat veins. And in 2011 and also 2015, America and Europe both also published their guidelines saying the same thing. And so what we know now is that if you have venous leg ulcers, or actually any varicose veins that need treatment, secondary to superficial vein reflux, your first option is endovenous thermal ablation, and we'll come to what techniques that encompasses in a minute. The second, and only when you can't do endovenous thermal ablation, either because you don't have it or the veins aren't suitable, you go to foam sclerotherapy. Although those of you who have followed my argument so far will know that you actually use both, because you use endovenous thermal ablation or high intensity focused ultrasound for the reflux, followed by foam sclerotherapy for the subalcer plexus. But you shouldn't use open surgery or stripping now unless you are unable to perform endovenous thermal ablation or foam sclerotherapy, or the patient is not suitable for either. And in 20 years, I can say I haven't found a single patient who we cannot treat with endovenous surgery or foam sclerotherapy, and we've ended up having to go back to open surgery. I mean, nowadays I can't even imagine the situation where I'd ever operate with open surgery, because we know the results are so bad. I would hope that it doesn't happen anymore, but I am aware that some doctors still do it, and hopefully they will learn the new techniques soon, because the good of the patients is clearly to ablate the veins. And we'll come into some of the pathophysiology to explain that now. One of the problems about endovenous surgery, whether you're talking about endovenous thermal ablation or whether you're talking about sclerotherapy, is there's still this idea from a long time ago that somehow you're sticking the vein together. And whenever you hear that, you have to be very, very worried about who's talking to you, because you can't stick the vein together unless you're using something like a cyanoacrylate glue. If you were just damaging the inner layer, the endothelium, and sticking the walls together because you damage that, that's what you do every time you put a cannula into an arm in the intravenous line and get a thrombosis. And we all know that that opens up again. So not surprisingly, we also know that those techniques that are shown only to damage endothelium but leave the rest of the vein wall living open up again in the fullness of time. So that's called closure by thrombosis. Whereas what we want to get successful treatment is closure by fibrosis. And the only way to do that is to kill the whole vein wall. And this idea of transmural death of the vein wall, I first published in 2004 in a book, and it's now started to gain traction, and more researchers starting to look at this and understand this is what we need to see happen if we want permanent ablation of any vein. So the mechanism, to make it nice and simple, and I've taken this from my book on leg ulcers, is if you have a vein over here that's normal, if you only damage the endothelium in the intima, the inside of it, you will get thrombosis. And when you do a scan, you'll say, oh, that's great, the vein's closed because you've got clot in it. But if you go back between 1 and 3 years later, you start to see it all reopening up again. And that's why you get recurrences. So when you've gone to a unit that doesn't do veins particularly well, and you think you've had them treated and they all come back within a year or two, this is one of the commonest causes of it happening. Now, if you use the correct amount of, whether it's substance or power, we'll come to this in a minute, depending on what technique you're using, and you get transmural death, you will end up with a complete constriction or fibrosis of the vein wall, and your body will eat that away, and that's involution. And that becomes totally fibrosed, and there's absolutely no way that vein is ever going to open up again. And our 15-year results that we've published a few years ago has shown that once you've closed a vein, it will never open up again if you close it properly. So we're now going to run through some of the ways we can ablate the veins. I'm going to start with probably the commonest that's used. It's common because it's quite simple to use, but it's not great for complex veins, although it's very easy to treat simple veins with this. And this is called the radiofrequency ablation catheter, or segmental RFA. The one that most people use just has a 7 centimeter end. There's a version with just 3 centimeters, but what you do, you put this block up inside the vein, and when you heat it, you ablate 7 centimeters at a time and pull it down. This has been modified by a different technique more recently that actually has the option of either having 10 centimeters or 2.5 centimeters, so it gives a bit more flexibility as to what vein you're closing. A forward-firing laser is just represented here, and what happens with a forward-firing laser is the laser energy is pushed out to the front of the tip of the laser, and that then transmits, and provided, just like RFA, provided you give enough energy to get through the vein wall to cause transmural death, you'll get a good result. But just with any of these techniques, if you don't give enough energy and you don't get that transmural death, you won't get the long-term fibrosis and involution. And this is just some liver experiments we do just to prove what actually happens and how the damage is forward of the end of the laser when you're using a forward-firing laser tip. The much more modern way to provide endovenous laser is the radial laser. And this is a very clever device that passes the laser energy out of the tip by having a special conical end and little air bubble in a plastic tube at the tip of the laser. And this gives you a much more precise way of treating tissue. That means you can concentrate the laser energy. And if you're using a wavelength that's absorbed by water, all cells have water into it. And this means you can be incredibly accurate as how to ablate the vein. And we can see here in this liver experiment exactly where the energy has come out of the tip of the radial laser. And this now is becoming one of the industry standard ways to treat veins accurately. This here is from one of my PhD students who looked at the differences between forward-firing and radial lasers in vitro veins, in other words, veins that have been removed at surgery and patients have given their consent for us to study. The treatment was done outside of the body, so therefore as a model, but you can see here this nice blue vein. This is the control. This is what it appears to be when you have not treated a vein. The red here is a special stain that shows fibrosis, and you can see with a forward-firing laser, one with a jacket tip, you get this very, very deep burn on one side of the vein, and on the other side, very little burning. Now, that looks really quite eccentric, and it does still give a good clinical result, but of course the risk over here of perforating is higher. And if this didn't have a jacket on it and it was a bare tip, this would be narrower. It could even perforate through the vein wall, which would still work, but it's much more likely to cause pain. This here is what you see with a radial laser, and you can see very, very nicely there's a nice concentric damage all the way around the vein wall itself, and you can see it's a much more elegant way of getting a good closure of the vein. Foam sclerotherapy is a very nice technique that's become very popular. One of the things you do with foam is you can mix it, preferably with carbon dioxide and oxygen, but some people use air. Under ultrasound control, you can see how the foam pushes the blood out of the way. And why we do that is it's blood that inactivates the sclerotherapy. And if you can push it out of the vein, then you'll get a good result. So pushing the foam into the vein like this under ultrasound control, pushing the blood out of the way, and then compressing the vein wall afterwards will give a good result, provided and there's a couple of things that you have to be careful of, provided the vein is small enough to be treated, and I'll explain that in a minute. It's not very good in big veins. And the other thing with foam sclerotherapy is you then have to wear the compression afterwards, because you don't get any contraction of the vein like you do with the heat ways of treating the vein. And so therefore the only way you get good results is to bind the leg or wear compression for a good 2 to 3 weeks to make sure that you keep all of the blood out of the vein when it's healing, and to prevent getting phlebitis or thrombophlebitis, as we spoke about earlier, superficial venous thrombosis, and brown stains. Now this is explained a bit easier in this cartoon using the same sort of format as I used before, once again taken from my book. This is if you have a large vein like the great saphenous vein or the small saphenous vein and you use foam sclerotherapy, you only damage the inner layer, probably out to about 200 microns. You get your thrombosis and your recanalization. And this is why people who are trying to use foam sclerotherapy instead of surgery are starting to see really quite poor long-term results, and patients having to have redo after redo after redo. Now, there are arguments about it being cheaper, but most patients really want to have a good result. If they have their treatment, they want to go and have it treated and really don't want to go back and have a treatment again. And this old idea that varicose veins always comes back is not true. If you treat patients and treat the veins scientifically, the risk of them coming back again now is very small every year. If you use a nice small vein here with a thin wall, the same amount of damage causes the transmural death we're trying to get to, which causes fibrosis and involution. So again, you can use foam sclerotherapy provided you have a small enough vein with a thin wall, or a big vein with a thin wall, but when you're using the big truncal veins, it's highly unlikely you're going to get a very good result if you're only using foam sclerotherapy and no additional way to make it enhanced. Without getting too technical about it, this is some of the proof of what I've just said. You can see the clinical proof just by looking at the randomized controlled studies, but we took this to the laboratory, and again one of my PhD students did this immunocytochemistry. Here we see a normal vein with normal immunofluorescence, with the lumen being over here, endothelium, and all of these smooth muscle cells here. And after treatment with sclerotherapy, the inner part is damaged, but not the outer part. And this leads us to this area which can cause thrombosis, and then this can grow into it and reopen again. And this is the proof that it only goes out to about 200 microns in this study that we did. And we did this with several different patients, and this just fits very clearly with the clinical results we find. So moving away from truncal veins, we're now going to talk about perforating veins. And in 2001, we published the Trlop technique, or transluminal occlusion of perforators. It was hidden away inside a different abstract, and so most people didn't notice it. In 2007, it was sort of reinvented and recalled PAPS in the United States, but it's exactly the same technique that was first described by us in 2001. This is a picture here by Barry Price showing very clearly what happens. You have one operator holding the ultrasound. You cannulate the perforator to the point of the fascia. This is it in real life. And then you can put down a radiofrequency probe. You can put down a laser probe. You use thermal ablation. You can even put down microwave. You can even put down glue, and you can do this as a non-thermal technique if you like. So the Trlop technique is purely and simply showing that using ultrasound, we can get into the perforator itself, and we can close this with a single needle hole, showing that it is quite possible to treat perforators under local anesthetic, as we've been doing now for many years. Although the guidelines all say that you must use or should use thermal ablation, there are now some new techniques coming out that don't use heat. And because they don't use heat, they don't need so much local anesthetic, and therefore may be more comfortable. And so the arguments at the moment is, are they as effective or not? And so there's a lot of information going on, but one of the techniques is called MOCA, or mechanical-chemical ablation. This can be by Claravane, which is the leader in this area, or the more recent Phlebogriff. And the idea is, with the Claravane one in particular, you have a rotational force, and some research we've published shows that this actually rips the vein wall, not just the surface, but it causes a shearing stress, and you get a ripping deep into the vein wall. With the sclerotherapy put afterwards, and that actually closes the vein permanently. And this is a very elegant technique to close long veins without any local anesthetic. And although ripping may sound awful, in fact this is microscopic ripping, and the patients rarely feel any problem with this at all. It feels like a gentle vibration as it's being done. A new technique as well is Acrylate glue or super glue. This again is pushed in with one tiny bit of local anesthetic, but again, because it's non-thermal, there's no heat problems and therefore no big local anesthetic put up the leg. This is a case that we did showing a vein open beforehand and glued shut afterwards. And so there's now several companies producing cyanoacrylate glues, and this may be something in the future, and certainly there's a lot of controversy and research at the moment as to the pros and cons of this versus thermal ablation. So the new kid on the block, and probably the most innovative thing I've seen in the last 20 years in vein surgery, is the new HIFU, or the high intensity focused ultrasound, which is totally non-invasive. And it seems absolutely incredible that you can treat veins from outside of the body without anything going across the skin at all. Now, in some patients, they do like to have local anesthetic, so you can use a tiny little needle, much smaller than anything you put in for the lasers. But with the latest technique called Sonovein S, in half the patients we've treated, we haven't even had to use any local anesthetic at all. So this is truly starting to get to that stage that we've all dreamt of, like on Star Trek, where you can cure bits inside the body without even breaching the skin. So the HIFU has two ultrasound systems. The first, this grey one in the middle, is beaming this linear grayscale ultrasound, and this is the sort of picture you get here on the right. And you can see this vein here with a bit of local anesthetic around. In this case, when you don't use local anesthetic, the vein, you can see the hole in it, so it's still easy to see in some patients. When you've targeted the vein, you then switch to the second ultrasound system, which is here in purple, which is a dome, and this focuses ultrasound down onto one point deep inside the body. So as it goes through the skin, the ultrasound energy is spaced out and doesn't cause any damage. And as it focuses down, it causes this burning right where this red dot is. Now on the ultrasound, that's right in the middle of that white cross. And at that point, any tissue in that area is being heated so much so that it will be ablated. And of course, what we've done before, we've aimed that cross to be exactly at the point of where the vein is. And this is what we see immediately after treatment. Here, what was vein before is now just a mass of little white bubbles and reflections, and that is the treated great saphenous vein. That is treated about 3.5 millimeters to great saphenous vein. So the robot arm now moves down, you treat the next 3.5 millimeters, moves down, next 3.5 millimeters. And with the new Sonovein S, this is now becoming fast enough to actually be an alternative to other endovenous thermal ablation techniques. So I think with more research, this is certainly something that we need to watch in the future, as this is likely to have many advantages over different techniques that are available at the moment. So using the same sort of diagrams that I used before to show how this works, uniquely what this is the energy is not coming from inside the vein wall and inside the vein lumen rather, and trying to go outwards to make sure we've got a transmural depth. This is ultrasound focused energy coming into this egg-shaped area here, the target area, which engulfs the whole vein wall, so that we get cooking or we get ablation right the way across the vein, right from the beginning, causing that fibrosis that we want, with no thrombosis and straight on to involution. So this has all the principles of very good results because it's based on good science. And we're starting to produce, and recently we've presented our work on the results of this, and I'm shortly going to publish our updated results on how good we are finding this in the majority of veins. So in summary, if a patient has a venous leg ulcer due to superficial vein reflux, then the saphenous veins can be treated if they're the incompetent problem with the endovenous thermal ablation techniques, which is basically endovenous laser or radiofrequency, although it's possible now to use the new microwave techniques or steam. Those currently aren't in the guidelines, but certainly are effective. Or you can use the non-thermal effects such as glue or mocha. They're non-tumescent, non-thermal techniques, However, those at the moment aren't in the guidelines. They're just starting to be approved, but certainly are effective in the right hands and used correctly. And also, of course, the new HIFU technique, which is the non-invasive technique. For perforators, the Trlop technique, which some people have latterly called PAPS, but was initially called the Trlop technique, or of course the HIFU technique, which is very effective for closing perforators, can be used to stop the reflux. The subursal plexus, which all of these patients have, really should be then treated with foam sclerotherapy, and that's also treated for useful for neovascular tissue, such as the strip tract vascularization if somebody's had stripping before, or if the patient's got complex tissue, which we've called parva and published previously. So we've extensively looked at reflux, and then we looked at stasis. Now just a quick word about obstruction. So obstruction is the third cause of the venous leg ulcers, and many people who are told they have deep vein reflux actually have an obstruction, and the reflux that's found with a duplex ultrasound lower down is secondary to a more a more proximal obstruction, something that's up inside the pelvis. So anyone who's diagnosed as post-thrombotic syndrome, who has a duplex of a deep vein reflux, should not be written off until they've been checked for an obstruction inside the iliac veins, because these are now amenable to being opened by stenting, and many people with swollen legs who have previously been told that their venous leg ulcers and great big swollen legs cannot be treated, can now be treated successfully with stenting. That might not cure the problem, but in those patients who are suitable, it certainly alleviates a lot of the symptoms. So therefore, in conclusion, most venous leg ulcers can now be cured with ambulatory surgery. That means walk-in, walk-out surgery, provided the patient is mobile and provided they have a good ankle joint movement, which means they can use the vein pumps in the legs. As we said, as most patients have got superficial vein reflux with or without perforated vein reflux, in some cases perforated vein reflux alone, then the essential things is to find the incompetent or truncal vein reflux, find the incompetent perforators, and find and treat the subursal plexus. And all of those can be found with venous duplex ultrasonography, and all of those can be treated by the techniques I've spoken about earlier. Those patients with deep vein reflux, most of those are mainly obstructive and therefore can be stented in specialist centres if needed and possible. Those patients who have combined superficial veins or perforated vein reflux and also deep vein reflux, the easy thing is to treat the superficial vein and the perforated vein reflux first to improve the patient, and quite often that's all that's needed. If the patient has got a lot of swelling and still has problems, then of course they may well need to be referred for stenting and treatment of deep vein obstruction in the pelvis. Although fortunately these are very few and far between, and most patients who are mobile with good ankle joint movement with venous leg ulcers fall into the superficial and perforated vein reflux and can be treated under local anaesthetic by walk-in, walk-out treatments, and the cost of doing that has been shown to be approximately the same as 1 year of dressing and compression. So it makes cost-effective sense, as well as good treatment for patients and their relatives, to actually have them assessed and sent for treatment rather than just continuing compression, which never ever corrects the underlying cause. So we've now come to the end of the hour slot. In fact, I've run a little bit over. I'm sorry about that. But I hope this has been useful. I hope it's dispelled some of the myths and some of the misconceptions about superficial venous thrombosis, or as it's called, phlebitis. And I hope this will start to lead people to getting better treatments, and healthcare professionals who've been listening to this hopefully will start changing their minds about just giving people antibiotics or support stockings and start to understand what's actually going on. And similarly with venous leg ulcers, stop wasting money by just compressing them all the time. And if the patient is able to mobilize and has good ankle movement, then go for the cheaper option, which is ultimately better for the patient, better for society, better for everybody concerned, their relatives, quality of life, and any way you look at it. So we are going to talk about the College of Pathology meeting. We'll talk about these sorts of cases and many more. We'll talk about some of the new techniques, show live cases as many of the new devices that are available. As with almost all conferences this year, because of COVID, it is going to have to be virtual, but we will be having live cases for people to watch as we're doing the show, and people will be able to comment and ask questions live. If you're interested in attending and registering, it's going to be on the 18th to 19th of June. Please log in to thecollegeofphlebiology.com. Thank you very much. And if you do have any questions, please do not hesitate to contact me through the College of Pathology website.